Yes, people, I'm back. It's been 3 months since my last upload. Today marks the 3rd month anniversary. I know it's not something to brag about, it's quite embarrassing, but you know, I was revising for these exams, which are super important and literally make up half my FPAS score. I'm a 4th year medic, aka 3rd year graduate entry medic, but we call ourselves 4th year just to avoid the confusion. But yeah, so there was a lot riding on these exams, so I was just, you know, trying to knuckle down. And because my laptop is turning 10 this year, literally a decade old, I've kept it in pretty good nick, but it's just super slow. Editing takes 2 to 3 times as long as it normally would on a normal functioning computer. So yeah, it would have just taken a lot out of my time just to edit the videos, cut everything together and upload it onto YouTube. So I just didn't want to do any of that. I just wanted to focus on revision. The exams happened 3 weeks ago, and I've just been, you know, spending the last 3 weeks just trying to chill with friends and family, just to forget about everything, properly de-stress, because the last few months have been very, very hectic indeed, especially because our exams that have just passed were purely synoptic, which basically means anything from year 1 to up till now, you know, could come up in the exam. So there was a lot of pressure. There was a lot of content to go through. I try to cover most of it, but I try to cover the most important stuff, and I'll, you know, make a video regarding the 80-20 rule, the Pareto's principle in the future, and how to use that before you even start revising for exams. But yeah, so I just thought it's been 3 weeks, but I didn't touch medicine at all. It's time to get back because I don't want to start my final year, you know, on square one, you know, on a blank slate. So I just thought, why not just attempt some past medicine questions. This video is sort of like a study with me video, but relative to the traditional format, this video is hoping to be more interactive. So what I'm going to do is I'm going to answer questions on past medicine, which is a great resource. I mean, I'm not sponsored by them, clearly. Look at my sub count, 84 subscribers. Yes, I'm a long way away from any sponsorships, but you know, past medicine is a great resource. A lot of people swear by it. In fact, I've spoken to a lot of medical students and even foundation year doctors who are freshly out of medical school, and they literally said, some people even said, past med was the only thing that they did and they passed comfortably. So it's a good resource, but for me, I'm the type of person who doesn't like keeping all his eggs in one basket, so I sort of like to diversify my study material and resources. So basically I use 2 or 3 other websites, like there's Kesmed or Quesmed, and then there's BMJ on examination, which is great because it has the most quality control. But today I'm just going to be focusing on past medicine, so I'm going to be doing a couple questions, 10 or 15, because I don't want to drag this video on for too long. And so compared to, like, you know, the traditional study with me videos where I see, you know, the person recording the video just does their own thing, and you know, whoever's watching, the viewer, does their own thing, and there's no, you know, there's no interaction. What I'm going to do is I'm going to basically answer these questions. I'm going to read through the questions, you know, verbally work through these questions and just, you know, think out loud, and hopefully you guys will be able to relate to what I said. And hopefully that way it's a bit more interactive. So I want you guys to work with me, you know, answer the questions vicariously through me, through your computer screen or your iPhone screen or phone screen or whatever screen that you're watching this video on. But without further ado, as you can see from this screen, I just clicked all the questions. I think there was like there's 6,500 questions in total in the final year medic pack. I've done about half of those, a bit less than half of those. So I've got another 3,600, 3,700 nearly questions to do, and I'm just about to start. Haven't looked at this question yet, but we'll see how we go. All right, so we've got here a 59-year-old male with type 2 diabetes, hypertension, and he presents at the clinic for a checkup. You know that his blood pressure is 145/90. Okay, so he's got like stage 1 hypertension, he's diabetic. His current prescription includes ramipril, which is an ACE inhibitor for his hypertension. So he's already on ramipril. You note the following most recent blood results. So HbA1c is basically like the amount of glucose stuck to a red blood cell essentially. And I think the normal value has to be less than 48. So this is 63. So it's quite He's got diabetes, basically. I mean, it's there in the stem, so I don't know why I'm trying to break that down. But which one of the following additional antihypertensives should you avoid? Oh my god, I hate these negative questions because I keep forgetting to read avoid, or like, you know, which one of these is false. I always get these wrong. Should you avoid? Okay. So amlodipine a calcium channel blocker. I think you would. So you give ACE inhibitors for someone with diabetes. Okay, I think it's that, but let's see. Atenolol's a beta blocker. Yeah, you could give it. Indapamide. I don't know what that is. Is that a thiazide diuretic? Yeah, surely you add thiazide diuretics to manage hypertension. So that's right. Lercanidipine, that's another calcium channel blocker. Okay, so we've got two options here. That's brilliant. And doxazocin. I don't know what that is. So that could be the right answer, to be honest. Yeah, I don't know this one. This is brilliant, isn't it? First question, and I'm struggling. Yeah, just the day that I decided to record myself doing these questions, which is brilliant. Amlodipine, I don't know. Indapamide. Thiazides can worsen glucose tolerance. Okay. Right, so here guys, I've just got this Anki flashcards, and let me see if I've got that. I don't know how to, and let me see if I've got a flashcard about that. If not, I'm just gonna make a new one. So that's what I do. I just basically what I do is I just basically make flashcards on the questions that I get wrong, and I've just been doing that since like day one of this year. So I've got like, you know, over 1,000 flashcards, but you don't want to overdo it. Just this is quite important, so I might make a flashcard on that. It's a very niche question though, to be fair. Okay, I'll just make it later. I don't want to make the video drag on for too long. So next question. So I've got the first one wrong. That's great. So the second question. 74-year-old man presents with severe hematemesis. His blood pressure is 8. Okay, he's very hypertensive. It's probably because he's throwing up blood, which is what hematemesis is. He's got a past medical history of AF, gastric ulcer 30 years ago. He's currently taking dabigatran, which is an anticoag for his AF. Okay, although he is prescribed omeprazole, which is a PPI for the acidity, he says that he stopped taking this due to the diarrhea. The patient's given initial management, including blood transfusion, immediate endoscopy is arranged. So you are concerned that dabigatran is exacerbating the bleeding and would like to reverse its effects. Oh god. Okay. So this is reversal stuff. So omeprazole, no, because he's already on omeprazole, isn't he? Or it's just going to make it worse. I've got no idea. Let me be honest. I have no idea what roxizumab is. Vitamin K is to reverse warfarin, telepressin. I don't think it's a reversal agent. It's used for variceal bleeding, like esophageal varices. And protamine sulfate, I believe, is reversal for heparin. So that's wrong. Telepressin, yeah, it's used to clot blood, but I don't know if that's a reversible agent for anything. Vitamin K is wrong. That's omeprazole's wrong. By process of elimination, because that sounds quite impressive, doesn't it? Idaruximab. Oh my god, I struggled though, but apparently 74% people got it right, so yeah. Dabigatran. Alright then. Telepressin is used in the context of variceal bleeding, okay. Okay, yeah. Secondary to cirrhosis, or like portal hypertension. And protamine is used to reverse unfractioned heparin, which is not what this patient's taking. Okay, fine. 66-year-old, next question. 66-year-old on the post-surgical ward has been suffering from intractable vomiting This is abdominal surgery for colorectal cancer 5 days ago. Following a surgical review, it is confirmed that the patient does not need to undergo further surgery. The team are concerned that the patient is beginning to become severely malnourished and decided the patient requires treatment for their malnutrition. Is this something about refeeding syndrome, potentially? So which one of the following treatments is the most appropriate? So guys, always when you're answering questions like these, always read what the question's asking. So most appropriate probably means, what's the most sensible thing to do. It doesn't necessarily mean the most definitive treatment, because that usually means that, what is, nailed on to or guarantees, proper management. That doesn't normally mean the same thing as most appropriate. So most appropriate would probably mean, okay, so he's throwing up because he's vomiting. So you don't want to give anything, so you don't want to give that because it's oral, so it's just going to throw that back up again. That's oral again, so probably not. Total parenteral, so yeah, you want to go with parenteral nutrition via cannula already placed in the patient's hand. Oh, so there's two parenteral nutrition. So, and then percutaneous endoscopic gastrostomy tube. Yeah, you would go for it, but that's if the patient's not throwing up. Again, because this goes through the mouth, it's essentially going to be the same as any sort of oral stuff. So it's either between these two. And I do know from, being in my acute medicine or acute care placement, you normally give nutrition via a central catheter that basically goes through the femoral or the internal jugular. Okay. So strongly phlebitic. Okay, what is phlebitic? Inflammation of the walls of the veins. Okay, so basically what it's trying to say is you don't try. Okay, so when it's long-term stuff, so for example, feeding someone, parental nutrition is long-term, right? It goes on throughout the day. You don't want to give it via like a peripheral cannula, so first on the hand. You want to go through the central route, because the chances of irritating the smaller veins is a lot higher due to the continuous movement of whatever, in this case, nutrition. So I hope that makes sense. It makes sense for me. But yeah, let's just move on. Fourth question. A 62-year-old woman is brought to the ED by her daughter with a nosebleed that's been going on for the past hour. She has never experienced a nosebleed lasting for longer than a few minutes before. Her observations on arrival are all within normal parameters. What is the most appropriate management? So she's got a nosebleed. Again, appropriate means the most sensible thing that you want to do. And the most sensible thing usually means the least invasive in most cases. So here you want to start off, easy, right? You want to start off small. So cautery, I think that's like second or third line. Emergency ligation, that doesn't seem too sensible. She's just presented. Why would you go for a ligation straight up? Posterior pack, anterior pack, again, that's for like second and third line. Sit forward, yeah, so that's like usually the first line thing. When someone's having a nosebleed that hasn't stopped, you just sort of apply pressure to the nasal septum. Okay, initial management. It's with adequate first aid. Yeah, so basically, most appropriate, like it says here, initial management, basically. That's what it's asking. And I think anterior, or the packs are used for when the bleeding can't be seen. So if it's a bit more posterior or a bit higher up, then you want to go for the pack. And if it's visible, like in, the, what's that word? The Wenckebach's plexus, which is basically like this congruence of all the blood vessels, at the anterior part of the nasal septum. Because it's anterior and you could see it from inside, then you would want to go with the cautery. But again, this is asking about initial management, and you just want to apply pressure to the nose, regardless of whether you can see the nosebleed or not. I hope that makes sense. Yeah, that's pretty important. A 48-year-old man presents to his general practitioner with mild dyspnea. He has a background of metastatic carcinoid tumor and takes octreotide. So octreotide is a somatostatin analog, which is given for carcinoid syndrome, like this man's having. He does not smoke or drink alcohol. On examination, there is an ejection systolic murmur, heard loudest in inspiration. Okay, I've got pretty decent at murmurs over the years. I just hope I didn't shoot myself in the foot right now. But chest auscultation is normal. Jugular venous pulse is not elevated, and there's no peripheral edema. Okay, so systolic murmur can be four things. It could mean an aortic or pulmonary stenosis, because it makes sense if you think the blood's systolic basically means the blood's contracting, or it could mean tricuspid or mitral valve regurgitation. So now the second part of this stem, so this part of the sentence, now rules it down to 2, which basically means that it's heard loudest in inspiration. So that means, because an aortic stenosis is heard loudest on expiration, so that can't be it. Pulmonary stenosis is louder on inspiration, so that could be. Now, tricuspid regurgitation is also loud on inspiration, and mitral regurgitation isn't. So it's now between pulmonary stenosis and tricuspid regurgitation. Honestly, now because he doesn't have any sort of signs of right-sided heart failure, it's probably tricuspid regurgitation. There is no tricuspid regurgitation. That's brilliant. So, wait. Okay, so it's pulmonary stenosis here then. Alright, you know what? I've got unlucky here. If there was tricuspid regurgitation in the answer choices, I would have picked that. But because there isn't any, imagine if I get this wrong. Whew. Okay, right. It's pulmonary stenosis. Now, what is the reason? Pulmonary stenosis is correct answer. The valvular lesion is mostly congenital. However, in rare cases associated with malignant carcinoid, ejection systolic, heard loudest on inspiration. Okay. So what was it? Is pulmonary stenosis. Well, it just says it's louder on inspiration, and so is tricuspid regurg. It's louder on inspiration as well. But so that is pansystolic. So you can always hear it during the whole of systole. Right, okay. Fine. I'm pretty sure I've got a flashcard on that, so that should be good. Now, question 6. A 24-year-old man attends the ED with right-sided epistaxis. It's another nosebleed question. He has been sat forward, putting pressure. So it's already done the first step that we've seen previously. But the last 30 minutes when you review him. Examination with thudiculum speculum reveals a site of bleeding from the Little's area. Okay, yeah, so that's the other word for the Wenckebach's plexus. You know, I just like being a bit fancy, so I always go for the longer words. I'm just joking. Little's area, completely did not know that. He is currently hemodynamically stable and does not take any regular medication. So what is the most appropriate next step in management? So this basically, I think this question is trying to say that you can see the bleed, and as I mentioned previously, if you can see the bleed, you go for the cautery, and if you can't see it, you go for the packing, the nasal packing. So, yeah, so I think that's cautery. Cool. Apparently that's very important. 90% of the people rated it important. So epistaxis from anterior bleeding source is visualized. That is visualized as treated with silver nitrate cautery. Yeah, cool. Okay, this is a chunky question. 26-year-old female is referred to the AMU with chest pain. The pain is sharp, left-sided, worse on inspiration, and worsened by lying flat. Okay. So she seems to have some sort of, is it ACS? It's like a mix between ACS and heart failure. She's got the pain, but then it's worse by line. Okay, let's just read on. She has no significant past medical history and is not on any regular medication except the combined pill. She does not drink or smoke. Her OBS are 92. Okay, I'm happy with the heart rate. I'm happy with the blood pressure. I'm happy with the respirate. Oxygen stats I'm happy with. I don't think she has a temperature. I think it's 37.8 for to be deemed pyrexial or feverish. ECG demonstrates widespread ST elevation and PR depression. That's got to be pericarditis. Yeah, widespread. So if it's like a global ST elevation and PR depression in all the leads, which is basically what global is, it signifies pericarditis. What is the question? What is the most appropriate immediate management? Okay, so for pericarditis, the immediate management would be NSAIDs and colchicine. Yeah, there you go. So I don't even know what colchicine is. Let's just look it up real quick. A yellow compound present in the corms of colic. It's used to relieve pain. Okay, fine. It's sometimes used for gout. It's basically a painkiller or an analgesic. Fine. Colchicine. Okay. A 27-year-old. So question 8. A 27-year-old woman who is 39 weeks pregnant presents to her GP with a 2-day history of dysuria and suprapubic discomfort. Could it be like a UTI? She has had several UTIs in the past and feels like she has developed another one. There is no renal angle tenderness and she is apyrexial. She takes no medication and has no allergies. The urine culture was obtained and shows E. coli with the following sensitivity information. So this E. coli in particular seems to be resistant to nitrofurantoin and cefalexin. So it seems to be sensitive, to nitrofurantoin or cefalexin, and is resistant to trimethoprim and amoxicillin. So all 4 of these antibiotics can be used for UTIs. But then this question basically rules out 2 of them. So trimethoprim you can rule out because it's resistant. Amoxicillin you can rule out because it's resistant. So now we're left with either nitrofurantoin or cefalexin. Now this woman is 39 weeks pregnant, which means that she's comfortably in a 3rd trimester. And in 3rd trimester, you're not allowed to give nitrofurantoin because I believe it causes hemolytic anemia in the newborn, if I can remember correctly. So the only answer left is cefalexin. Cool. Nitrofurantoin is avoided at term due to potential risk of neonatal hemolysis. Yeah. Because neonates have immature erythrocyte enzyme systems that increase the risk of hemolysis. It's also avoided in G6PD deficiency. Okay. I don't know if I've got that flashcards to be fair. I can always make flashcards in my own free time. Now, question 9. We're doing pretty decent, guys, actually. Like, we've come back. We've come back from a very rocky start. I'm actually proud of myself. I might have spoken a bit too soon. Watch me get this one. 47-year-old female presents to a normal diabetic outpatient appointment as part of her regular checkup. She is type 2 diabetic with a BMI of 30. Look, she's quite large. I think it's safe to say. She's currently on a 4-dose metformin monotherapy. Her HbA1c is 59. So 58 is a cutoff for adding extra medication. So she's definitely qualifies for something to be added on top of her metformin. She reports that she is compliant with the medication. After discussion, the patient feels that there's not much more she could do with lifestyle modification or diet and is willing to add, here we go, extra therapeutics to her management as needed. The patient reports that she would be keen to avoid any medications. Oh no, I can see where this is going. Any medications that can cause weight gain if more medications are to be added. With this in mind, which of the following would be... So something that doesn't cause weight gain. That could be right. That could be right. That could be right. Obviously, you don't want to continue metformin monotherapy because the question is talking about adding stuff, so no. Insulin causes weight gain. I know that for sure because it inhibits lipolysis. It inhibits lipolysis, and it can, one of the side effects can be weight gain. DDP inhibitor, sulfonylureas. I think that causes weight gain. I think sulfonylurea causes weight gain. So it's between pioglitazones and a DDP inhibitor. Guys, I'm literally going to take a shot in the dark here. Literally going to be like, eeny, meeny, miny, mo. Alright, I've landed on that. Damn, okay. So it's a DDP4 inhibitor. And I know I've made a flashcard on it because I've seen it the other day. I just have to read that flashcard in more detail, basically. But yeah, alright. I spoke it into existence. I said, watch me get this question wrong, and I did. Maybe I should be quiet for this question. An 18-year-old man presents to his GP with persistent facial weakness. He was treated 4 weeks ago for suspected Bell's palsy, at which point he was given a steroid regime and artificial tears. So basically here, people with Bell's palsy, because both the upper and lower face, so one side of the upper and lower face, basically the whole of one side of the face is sort of paralyzed in terms of the muscles not being able to work. You can't really blink as well because, you know, your eyelids are muscle itself. And that's why you need artificial tears. And I just found that out the other day, and I was like, a bit revolutionary. For me anyway. You guys probably already know it. But the patient was given a repeat course of steroids 2 weeks ago. Yeah, it makes sense. Probably, I think you give dexamethasone for Bell's palsy. He reports no improvement in his symptoms at all, but equally no worsening. Okay, so he's just like there. He states that there's no change in his paralysis and his taste is still altered. On examination, there is left-sided facial paralysis, including the forehead. There is no visible rash. Otoscopy is unremarkable, and so basically the ears are fine. And examination of the eye is reassuring. So the ears are fine, the eyes are fine, you know, everything's fine. Cranial nerve examination reveals no other abnormalities. What is the most appropriate next step in his management? Okay, so he seems to be fine. He's just not getting worse. That's viral. I don't think he's got a viral infection. Repeat course of steroids? Yeah. He was already given a repeat course of steroids 2 weeks ago. So would you want to repeat that again? It doesn't seem to be getting better. But there's no emergency either. So I would say routine referral to ENT. What? Urgent? Why? He seems fine. Am I reading something wrong? Did I hallucinate something in the question? For a patient with Bell's palsy, if the paralysis shows no sign of improvement after 3 weeks. Oh, wait, how long has he had it then? Oh, 4 weeks. Okay. Okay. I'll make a flashcard on this later. Guys, my hay fever is absolutely mad. Oh my god. I'm going to try not to sneeze. Okay, so basically, Bell's palsy, if someone has it for more than 3 weeks despite steroid treatment, you urgently refer them to ENT. A 45-year-old man comes to see you recent as his recent. What? Has come to see you recent as his okay. Fine. Have shown a total cholesterol of 6.2. I don't know if that is that high. I mean, it would be. Otherwise, it wouldn't be in the question. Cholesterol. Cholesterol is high. Okay, so the normal is below 5, 6.2. To be honest, my cholesterol is probably high right now because, boy, I've been getting takeaway every other day pretty much over the last couple months. But basically, you ask him to come in so that you can discuss this further. You calculate his Q-RIS to be 23%. He smokes 10 cigarettes a day and he's been smoking for the past 20 years. He's got a 20-year pack history. His father died of heart aged 50. His past medical history includes asthma. Now, which of the following medication would you ask him to start? So these are all statins, and I think you give atorvastatin for any sort of prevention. But now I think the question is like, is it primary prevention or secondary? From this, I don't think he's got any cardiovascular disease yet. So you'd go for the primary option, I think, because his Q-RIS scores 23, which is high. Q-RIS is like the likelihood of you getting cardiovascular disease in the next 10 years. And if it's over 10%, I think it's high, and you need to put them on atorvastatin. But I don't think he's got any other. He's got asthma, but asthma's not a cardiovascular thing. He's got family history of cardiovascular disease, but he himself doesn't have it. So it's between 20 and 80 milligrams. I think it's 20 because it doesn't mention that he's already has any heart disease. Okay, cool. And you give 40 when 20 is not working, I think. Or is it 80? It just says increase the dose, to be fair. But I think you increase it to like 40 if 20 is not working. We just answered question 11. Shall we just stop it? Just end on a high? Okay, let's do it. I'll do one more, I think. I don't want to keep it too long. 65-year-old. Okay, this is quite a chunky question as well. So yeah, let's just stop after this. 65-year-old woman presents to the postmenopausal bleeding clinic. She reports that her last menstrual period was 9 years ago, so she's definitely menopausal. But within the last 2 months, she has been experiencing vaginal bleeding with some clots. She reports no weight loss, abdominal or pelvic pain. 1 second, guys. No pelvic or abdominal pain. On further questioning, she reports that she has been pregnant once when she was 25, after which she took the combined pill until reaching menopause. Since then, she has not been on any hormonal or HRT. On further questioning, the patient reports that she underwent a total mastectomy at age 34 for breast cancer. So total mastectomy is like removal of the whole breast tissue. Following which she's completed a course of tamoxifen. Okay, that's a red flag right there. Tamoxifen causes endometrial hyperplasia, so that's probably why she's bleeding through the vagina. She has a 23-pack year history and drinks approximately 1 glass of wine a week. The patient reports that she has done some online research and is worried about the risk of endometrial cancer. Which one of the following factors in the patient's history puts her at an increased risk of the diagnosis? No. Yeah, previous medication for breast cancer, which is the tamoxifen. Because even though tamoxifen has this dual functionality, in the breast tissue, it helps because tamoxifen's like this estrogen-based thing. In the breast tissue, it helps, but in the uterus or the endometrial tissue, it has the opposite effect. It can cause hyperplasia, and hence that increases the risk of endometrial cancer. Cool. Yeah, tamoxifen may cause increased risk of endometrial cancer. That's because, you know, with hyperplasia, the more the divisions of the cells, the likelier the cell is to undergo this sort of mutation, if that makes sense. So I think that's the whole premise behind it. I should do a couple more questions, actually. I'm in the mood now. A 69-year-old woman is admitted to high dependency. This is sepsis stuff. Due to pneumonia, she's being treated with IV Kef. Okay, this is the last question. She has a past medical history of type 2 diabetes and 3 previous MIs. She takes amlodipine, which is a calcium channel blocker, aspirin, which is like an NSAID or an antiplatelet. It depends on how you look at it. Clopidogrel, which is an anticoag. Metformin, diabetic drug. Propranolol is a beta blocker. And simvastatin is in the name, statin. Okay, so during catheterization, it was noted that she passed visibly hematuric urine, so she's got blood in her urine. So that's like a nephritic syndrome, because nephritic is basically blood and a little bit of protein, whereas nephrotic is mainly protein. A urine dipstick was remarkable, so it got 3 pluses on the blood there, so that's a nephritic for sure. A set of bloods are shown below. So she's anemic. She has low platelets. She's got low white blood cells. She's hyponatremic. Her potassium's okay. So I don't know what's the word for normal potassium? Eukalemic. Urea is slightly high. Creatinine is high. CRP is very high. So something going on here. Some kidney infection kind of thing. Platelets are low as well. Well, wait. She's septic. Could it be DIC? Is there DIC here? Disseminate. Yeah, there it is. DIC. Because the platelets are low. And in DIC, but it didn't say anything about like the bleeding time, because the bleeding time would be high. Fibrinogen levels would be high. Drug induced? I don't think it is. Granulomatosis. IgA, that's nephritic. Pyelonephritis. She's septic, so I think it's DIC because they're very closely associated. Whenever you see sepsis, and if DIC is the answer, that's what I've been told anyway by one of the F1s. Like, if sepsis is in the stem and if DIC is in the answer or vice versa, always go for it. And, you know, she was right. She was definitely right. So thank you. Okay, I think that's it, guys. But yeah, that was it. I hope you guys enjoyed that. So let me know in the comments if this is something you want me to sort of do more frequently. I quite enjoy doing it because I think this is a kind of video that I would personally enjoy watching someone else do. But yeah, I hope you guys got most of it right with me. And apologies for getting the answer wrong to those people screaming, shouting the right answer at me. I don't think I'll be able to hear you guys. You're too far away. But yeah, let me know if you guys want more of this kind of content in the future. And yeah. Alright guys, in a bit.